When I do any presentations, particularly if I'm on the more west side of the county, I always say that you may not know me as Dr. Dial because I'm married to Dr. Dial. She is a practicing physician in Ojai, and we met in high school. So despite my entire CV of who I am, that's really who I am. I'm Mary's husband. And we have one daughter, and we couldn't be more excited that she's been married for a couple of years and hoping on grandchildren. So, but I am a geriatric family doctor. I have done an awful lot of practice in this county teaching, involved with the residency training program of the county, teaching community events, teaching physicians across the country about geriatrics, hospice, palliative medicine. I can speak on a lot of various topics on that. And today, the request was, let's talk about the aging brain. Now, I think what I should do is back up to about here and not move very much. Is that okay? You can see the slides if I sort of don't. I tend to walk a little bit, so I just don't want to be in front of you all when I do that. So that's the spelling of my name, Lanyard, like one of those things around your neck, dial, like dial the telephone. And as Martha said, I've been the medical person for Livingstone for now almost 4 years. And we helped set up their first hospice, the first hospice in Ventura County. So hospice always has a special place in my heart. But today we're going to talk the aging brain. And I'm hoping that this goes like that. Yay. And what we're going to do is we're going to look at the brain function and its structure so that you can get a good sense on what we're talking about, and there's some common general knowledge that I think you already have, but we'll go just a little bit deeper than that. Then we're going to talk about how that changes as we get older, what happens to the brain itself. We'll talk about how you do your best to try to preserve your brain function, how you deal with the aging part of it, and try to keep it as strong and functional as you can. And then we'll end with talking specific diseases of the brain. When you talk about anything with aging, there's two camps, there's two groupings. There is what's normal, what should happen to me as I age, versus that's a disease. And if that's a disease, it can be treated, potentially fixed, it can be managed, it can be watched. If it's aging things, we can't reverse that yet. So you have to separate out, well, what's going to happen to me just because I'm getting older versus I have a disease? Because if it's a disease, we can do something. So we'll think about that as we go through this. I always start with the concept that, as I said just then, you're all aging. We're all aging. No one gets out of this alive. We go through a process where we're young, where we grow up, where we learn, where we expand, where we figure out our organs and our systems and our life, to a process where we decay, to a process where we decline. Anything in life that has a life dies. Anything that's born goes through this same process and dies. That is the inevitability of us getting older. You could be an ant, you could be an oak tree, you could be a rose, you could be an elephant, you could be a human. You start little, you grow up, and then you age, and then you decline, and then you die. You go through that same process. We're really focusing on us as humans today and our brain and what happens to it. You could give this same talk for what happens to your heart, what happens to your lungs, what happens to your kidneys, what happens to your liver. Everything about you, we know what goes on as aging happens and how function slowly decays and declines until we do. So this is, hands down, the most complex organ of the body. That's good and bad. The good is it's incredibly complex, and you have had a brain that allowed you today to get here. There are many of your same ages who can't do that at all, who had their own diseases or aging process differences from you, and they can't be here. This is a very complex organ that allows you to do a complex set of tasks and things that makes us who we are. I had a neurobiologist as my geriatric professor. That's the gentleman who led the charge for me when I was in my training at UCLA. And he knew more about this organ than many people across the country do about it. And he said that, his name was John Morley, by the way, he said that if this brain were so simple we could understand it, we would be so simple that we couldn't. So if this brain were so simple we could understand it, we would be so simple that we couldn't. This is a hard organ to get your arms around. I believe modern medicine has done miraculous things. With understanding about the hearts and the lungs and the kidneys, we have developed dialysis machinery. We have developed transplantations to put new kidneys in. We have ways to manage without you knowing, taking out your heart and putting in a new heart. And the complexities of what we understand in healthcare across every organ is tremendous. Not this one. We have only scratched the surface of what makes this thing work. So unfortunately, I don't and can't give you every single detail on what makes it work. In fact, the further down you go in understanding it, the more you realize, wait a minute, I don't even know this. No, we don't. So it is really complex. Let me start with some of the stuff we do know. That's a normal brain. And you, today, I bet most of you would look at that and go, yeah, I've seen that before. It has a frontal lobe. It's tapered to the back where the occipital lobe is. It has an area on the sides called the temporal lobes. This whole thing peeking out down here is the cerebellum. So it has a structure that we recognize. It fits in our heads, and we have a skull that surrounds it. It is connected down into your spinal cord. All of that is a nerve connection down. So when you look at the nervous system, it is this top part of the brain, then the connections all the way down the spinal cord and nerves that go out. So we can recognize it. If we found it lying on the street, we know what it is. We have names that we've given lots of places on it. Let's go there. There we go. So we've given names to almost every little piece of it. And those names have come over the years of us trying to analyze it and figure it out. But basically, they're just names. They just help doctors, for the most part, communicate about where things are in the brain. There's no legend of fact that says this is this part. This is all historical. This is kind of like you trying to read a complex Bible and figure out where are places in the world these things happen, and they're all in names. This is all just names. There's no Bible about the brain. There is no fact sheet that we have. We gave the names to. That's it inside of you, and that's the cerebellum. It's now cut through the middle. That's the spinal cord as it comes down. And this is the middle half of it. There's a whole collection of tissues here in the middle that communicate across brain side to brain side. There are two sides, left side and right side, and there's a connection between them. There is your scalp as you go down, your periosteum, a top layer over your bone. So you've got scalp, periosteum, and bone before you even get inside. And once you get inside, you have layers of tissue that cover the brain. Think of them as saran wrap, and you have a few of them. You have a saran wrap called the pia mater. You have a saran wrap called the dura mater. You have an arachnoid matter. You have different layers underneath the bone that the brain is then inside, kind of like saran wrap. And then it has fluid that fills up that whole area around where the brain is. So that fluid then flows up and down your spinal cord and is called subarachnoid fluid. So the brain, here's where blood vessels run in between the saran wrap and the brain tissue. When we've analyzed people after they've died, or we go through experimental processes to sort of treat or manage things, we've come to learn of the brain where things happen. Like, what part of that brain makes you talk? What part of that brain lets you see? And you kind of know that back here in the occipital lobe is how I see. That language and problem solving and understanding and memory, big to all of us, is kind of here on these sides. Movement is kind of here in the top middle part. So we have been able to identify the areas of the brain that cause things to happen. Now, that's not very perfect because we don't have, there's exceptions to every parts of these things that it's just very interesting. And yet that's about as rudimentary an understanding as we have. Is that this is the area where if you come in with a brain tumor with symptoms that say your vision is having trouble, and it isn't your eyes, we know the tumor of problems likely to be in the back area of the brain. That's the crude understanding of brain function. That's the macro picture. It's kind of like saying, here's the United States. We know where California is, we know where Boston is, we know where the Mississippi River lies. But there are roads that connect everything. Your brain is made up of individual cells that are called neurons. Those neurons connect to other neurons. And they connect in a very important fabric structure. Think of a mesh of screen, of a wire sliding door screen. There's connections. If you push a hole through that screen, you break the connections. The connections are essential. The cells talk to each other. This shows you up here and down here, the little thing that looks like electricity. There's electrical communication between this cell and this cell because there's a connection that this cell sends to this cell. That electrical activity is essential to your life. We can measure it. We can put something around your head and measure electricity in your brain. And you've heard of an EEG, an electroencephalogram that measures electrical activity in the brain. And you've heard of seizures, where the electrical activity is wrong and it's just popping off and the brain is seizing. That's all electrical neuron to neuron connection activity that's going on. But what's fundamental to all your organs in your body is they're made up of cells. They're made up of small individual particles that interact and work together. In the brain, they're called neurons, and the connections are essential. They send electrical, and then I will now tell you chemical messages along this path. So this is a neuron or a nerve cell. Here are what I called before the kind of wire connections, but they have names. One is called an axon, and it's the longer of the two that send the information. at one that's called a dendrite. It's the shorter part of the neuron that receives the axon's information. So you have axons and dendrites. At the site where the axon hits the dendrite, right here, it's blown up in this picture. The electrical activity that comes along that axon does not electrify the next cell. It releases chemicals at the very end of it that then swim over to the next cell and activate that cell and tell it something. So you've got this incredible system of neurons, axons sending information. The information it sends is electrical. It goes to release chemicals at the end of it at an area called the synapse, where the axon hits the dendrite and it releases chemicals into the next cell. Those chemicals do whatever they're supposed to do to tell cells what's supposed to happen. You now know as much as science knows. Oh, maybe a few more things we know. We have some of the chemical names.
Acetylcholine.
Acetylcholine's a name. I've got a list for you. But you have some of the chemical names. We really don't know how all that works. How come I have been able to stand up here for now 20 minutes and talk to you? What's happening up here? Are there neurons firing electrical activities, releasing chemicals, finding the words in my file storage system? Those chemicals then are sent to my speech system. You want to talk complex? That's how it all works. It's all electrical and chemical interactions going on up there. Just bizarre. I mean, so once you get further into it, so let me give you a simple one. Why do we sleep? I don't know. Nobody can tell you the answer to that. Think it through. There needs to be, if you don't sleep, you're not going to be in good shape after a few days. So it's essential that you sleep. And what happens during your sleep time? You really don't know. There's still electrical things happening. They're a little different, maybe. There's still chemical things happening. They might be a little different, but we haven't figured that out. But are you taking information that's essential that you've used up because you've been awake and rebuilding it back so that you have it anew? Or have you built up so much trash it needs to be gotten rid of? It needs to be cleaned out so that you can be okay. We don't know. Another great example in the world is schizophrenia. So here's a disease where people hear things and see things all the time. They're hearing voices that aren't really there. They're seeing peoples and images and things that aren't really there. Their brain has the same electrical activity as all of our normal brains do. Their chemicals are exactly the same chemicals as all of our chemicals. Their x-rays, their structures, their pathology and autopsy, when we cut it all up, looks the same. Why can't their brain function like your brain functions? What's the difference? We don't know that. So, as I said, we know a lot. There's so much fundamental stuff we don't know. Okay, so here's the end of the axon. Here's the next receiving dendrite. Here's all these synapses and chemicals coming down and releasing and going across. We know from the axon down to the dendrite what these chemical receptors look like. We know what the chemicals are. We've got drugs to give more chemicals in here or to take some of these out. We've got drugs that block up these receptor sites. We've been able through the years to manufacture some pretty good chemicals that do things. And that's what we use to treat a lot of stuff. And it works somewhat. But is that really what we should be doing? Is that really how things are supposed to happen there? It's so complex. That's as good as we've got. We're going to give you some chemicals you're going to swallow. and they're gonna go around and they're gonna put a little bit more of this drug in that synapse, we think, and help you. So the classic one that was sort of first discovered and was really big was the chemical dopamine, where people who have an illness called Parkinson's disease, that wasn't what it was originally called, but that's what we ended up calling it, they had a lack of dopamine at this part of the world. So we gave them more. Here, take this dopamine. So we give a whole bunch of pills of dopamine. Well, that was a mistake because dopamine's very nauseating to people, so they just threw it out. So then we figured out a way to combine it with another chemical so that plenty of it would get up into your brain and wouldn't make you nauseated. Therefore, you have a drug now, very common, most standard Parkinson drug called Cinnamon. It's a combination drug that is sin, no more vomiting. That's the combination drug treating Parkinson's disease. And it places more dopamine here, and people do better. They can move better for a period of time. But it stops working. Your brain continues to need more and more. The chemical itself causes more and more problems. So all of this is left. I want to leave you with the idea that the brain is the most complicated thing we've got. It's got electrical stuff. It's got neurons. It's got dendrites and axons. We know a lot, but we know very little. So when you start to ponder and think, asking questions, I may get to a point where I say, we don't know that. The gentleman back there mentioned acetylcholine. That's the one that we think is depleted in people who have Alzheimer's disease. So we give them more acetylcholine. Now, you can't just give people acetylcholine because it also makes them sick. So you've got to reconfigure it, figure out a way to get it up into the brain where they don't make it sick. So we give them a breakdown enzyme of acetylcholine called acetylcholine esterase inhibitor. We stop the enzyme in the brain that's breaking it down to get more in the brain. Really complicated stuff. Serotonin, probably our most common drug these days that we treat people who have depression, is we give them SSRIs, selective serotonin reuptake inhibitors, very similar to the acetylcholine. We don't give them serotonin, we block its breakdown. Dopamine, I mentioned already, norepinephrine, GABA, glutamate, those are the neurotransmitter names we know, and we have drugs that interact with them, and that's how we treat them. There are one other important cell type in the brain to know about called glial cells. So, not neurons. This is the glue. This is, other than neuron cells, this stuff holds the whole brain together. This is the cells that clean up and scavenge all the toxic stuff that show up. These cells are the backbone structure that form all the framework that the neurons do their actions in. And there's different kinds of glial cells. I put them up because you might have heard their names. Astrocytes, oligodendrocytes, microglial cells. These are not in the brain, these are in the peripheral nervous system. These are the central nervous system ones. And they are important because there's been more and more written about how damage to them isn't good for your brain either. And how do we best understand their presence there and what they do. So besides neurons, the second major cell is just the glue cell. These don't have any ability to remember things or carry out actions. They're the fibrous background around which the nerve cells. Okay. We don't know how information in your brain is stored, coded, pulled back out. Don't get it. We don't have it. What we do know is you have some system in there that works really well so that you can remember things. and you've got it stored and coded in there, and you can, when you're growing up, add to that coded and stored information. When you get older, you can add to that recorded and stored information. There's a process that happens, we don't know how it happens, that you code the information and keep it in file cabinets, that then when you want to get it out, you go get it out, and it comes back out. Probably that's chemically contained. The whole file cabinet system is not a system designed to be electrical. It's designed, I think, probably to be chemically stored, but we don't know which chemicals stored. There's thoughts that it might be within the mitochondria, which is a little organelle inside the cell of the neuron that stores that information. But this is a real bugaboo, and we'll talk more about as we go along. How do each of these chemicals really work? We don't know. And the diseases that go on in the brain have left us wondering and trying to figure out, if we're going to treat this disease, what's causing it and how do we best treat it? In the example I used with the schizophrenia. So what we've learned is it's best treated with its drugs. And sometimes they work and sometimes they don't, and we try them on. But that's about as good as we can get. When you get into memory loss or delusions, even depression, we've got some chemicals, we've got some ideas, but it's not very perfect. Okay, that's the backside of how's the brain structured, what is its function, how does it work. Now we should talk about what happens to it when you get older. We've learned a few things about it. One, the number of neurons in your brain today is about 10% less than the number of neurons in your brain as you were growing up. Not 100% less, about 10% less. You lose about a percentage of neurons, 1%, over each decade of life. So there are a few less neurons in your brain. Not surprising. I think we all feel it at times that, okay, I've got, there went one. Less neurons in the brain. But this is the key part of it. What I told you at the very beginning was the importance of trying to figure out, how does information get in and out? How am I able to look at a slide, think about what I wanted to tell you, process that quickly, and get it back out in a matter of split seconds? Or I'm going to walk across this room. What does that take? It takes my brain's ability to think through, I'm going to take steps in this direction while my head's turned this way, process that information, send it back down to my muscles of my leg, and make it all work. Okay, the speed of all processing of information slows down as we get older. So, we are not capable of running as quickly as we were. We're not capable of dealing in the complex movements that it takes to perform heavy level, high duty, heavy area sport activities still. Not just the muscle strength, but even just the quickness and speed that it takes to make those things happen. We slowly walk, and we take a little bit less of a girth of a step. Think about walking. I'm just falling forward. I'm falling forward, and I just put a foot out to catch it. I mean, that's how I command myself to walk. I roll myself out there and catch it. I do it a little smoothly, but that's the fundamental idea. But if you're not going to catch yourself as quick, you're not going to take as big as steps, and you're going to go slower. So gait changes happen because of processing of information. So you've lost some neurons and your information isn't processed very quickly. You're not going to be as good at remembering where you put your keys. Or who was the actor in that movie you watched last night. or telling somebody the story you've said before because you can't quite get in the right order. That all is normal aging processing of information speaking. We don't get it. Give yourself a break. It's just you don't have a 20-year-old brain. When you take a child, you know this, you take a child and you teach them 8 languages as they're growing up. They're going to learn 8 languages. Try to teach us 8 languages. It ain't going to happen. I mean, can you learn and process? You can. But the speed at which they can absorb and write that into their brain and re-access it, you know what's doing it? I'm guessing there's some chemical thing there. It's much, much quicker than the speed at which we do it. So this is really important. This processing of things that slows down makes us much more susceptible to falling over, to being unstable in things, to forgetting things. We know that the processing of both visual stuff and auditory stuff slows a bit, so it takes longer to get all that information. Normal age, that's not a disease, nobody can fix it. That's what's going to happen to all of us, that's what's happening. Is there a loss of memory? Everyone wants to talk about memory because of the prevalence of Alzheimer's disease, and we will talk a little bit about Alzheimer's disease. Is there a normal aging memory loss? Absolutely. And the key to distinguishing normal aging memory loss and disease is it causing you significantly functional problems? Function. Can I get my clothes on, cook my meals, manage my money, shop for things? If you can do all those things, you do not have a dementing disease. The fact that you can't remember where you parked the car exactly when you walk out of the, is it that lane or that lane? Or you get to Costco and now you're totally lost. I like kidding the lady as I'm walking out with my receipt. And I say, do you know where I parked my car? Because that's the classic of we just don't process it as quick. It's not put in there as well. So normal aging, you lose a little memory. A good question that I found that you can use is if you're worried about somebody's memory being more than just normal aging, ask yourself, could I leave this person alone in my house for a weekend? And would they be okay? And if you go, then they probably have a disease. There's probably a significant problem of their brain that you should have checked, not just a normal part of aging. Okay, how are we going to keep our brains healthy? What can you do? I'm just going to reset my clock here since somebody decided they were going to call. How do we keep our brains as healthy as they can be? What are the facts? Because there's a lot of mess up. Everybody and their brother wants to publish something, write something, tell you what to do. And this last week, I've seen lithium. That's the answer. You need more lithium now.
To say, have a very good diet, get some exercise, don't smoke, don't drink.
So you're using the common sense of what every good doctor would tell you. The key thing that we have the best evidence on is exercise. Keep exercising your body, walking, moving, and keep exercising your brain. Go to lectures, interact with people, watch movies and talk about them, read books, do puzzles, play cards. Keep active both your brain and your body. That has the best evidence for helping preserve the function of your brain the longest. Puzzles I love. Crossword puzzles. Any kind of way that you try to make your brain work more. Because the logic is that you're taking the screen door and creating more of those connections. You're trying to force more. I don't know if that's true. So if there's a little hole, there's more connections around it. Nobody knows, but that's what they're thinking. So keep using your brain, keep using your body. There is no evidence along the way that there is any pill that's going to help your brain live longer, be stronger, be healthier. No vitamin. So you'll hear, you got to take that vitamin E. No, it's the fish oil that helps your heart, not the brain. No, you need to be taking calcium more, lithium more. Nothing we have any proof on. So don't leave here thinking that there's some pill you can take that's going to preserve the function of your brain. Won't happen. And if you've got one at home you think you're taking that's working really well, okay, I can tell you that I can give any of you this pill, and 30% of you are going to find it works no matter what I tell you it does. So I get that. But there is no evidence that there's any neuroprotective drug out there. This one is for your blood pressure and your health. Absolutely. If you've got high blood pressure, it's one of the biggest damagers of brain function. So you got to make sure you control your blood pressure. You got to make sure if you're supposed to be taking blood thinners because you're prone to getting clots to your brain, that you take your blood thinners. So this is a diagram to say the circulation in the brain is really important. I mentioned how easy it is to fall because we're not as quick to catch ourselves. Our system doesn't process information as well. Falling and hitting your brain is a bad thing. So anything you can do to prevent yourself from falling is good. What can you do? Exercise. If you're losing some functional ability, have it checked out by a doctor and a physical therapist. If you need an assisted device, a cane, a walker, get them, use them. I find too many seniors who go, I don't want to use that, it looks funny, it feels weird, I don't know, because that is the problem. If you fall down, you're going to have bigger trouble than what you think you're going to have with using an assisted device. So use them. Brain food, you mentioned that. We don't have really good evidence on brain food. We don't have really good evidence on food in general. Our evidence on food tends to be from population studies that say, this Mediterranean diet thing is really good for you. Well, so are Mediterranean genes. If you live in the Mediterranean, you've got Mediterranean genes, that's good for you. And that's why you eat a Mediterranean diet. Can you transfer that? Not as well as you think. When we went to the Japanese, people are living really long and they eat a lot of rice and fish, but it had nothing to do with the rice and the fish, it had all to do with Japanese genes. So we can't today tell you this is the diet that's going to keep your brain working the longest and we all should be on. We don't have that. Socialization definitely helps you. Being out amongst people, talking to other people, communicating, being a part of another person's life, and having an interaction and reading books together and going to meetings and you talking to each other. I think it's a great concept for us to be much more social and not isolated in a smaller place. One of the reasons I think residential facilities are good as people age is that I like living in my own home, but my own home is quiet. If you're into a facility, you're forced to interact and be involved with people. That's better for us as people. So socialization, I think, is really important. There's lots of talk about stress reduction, about yogas, more than just posturing, but meditation, being good for the brain. Again, not a lot of evidence. So this has soft evidence to it, but it's pretty soft. So, if it fits into your life and you can incorporate it and use it, I think it's a good thing. There's no evidence that said any of this is bad for you. Like the falling is bad for you, or the drugs that people are pushing and saying, oh, you should be taking this bad for you. Don't do this. 15 minutes or so talking about diseases. So that's that's brain structure and function, that's normal aging, and how do you preserve your brain from normal aging. Now we're going to go into, there's a lot of diseases that happen that you should know about. And we have treatments for these various diseases or not, and there are important parts of it. Headaches tend to be not big deals in the brain. They tend to be a big deal, but they don't tend to portend a lot of bad stuff usually. Seizures, immune conditions, infections, pituitary gland issues. This is like thyroid diseases, pituitary mixed growth hormone, those sorts of things. But this is the big five I want to focus on because those are the ones that you should know enough about to recognize and come out of here. So let's do tumors. There are two groups of tumors to the brain. Primary brain tumors. Primary brain tumors are almost all glial cell tumors. Okay? They aren't the neurons tumors. The neuron themselves rarely, and the thought here is it doesn't really divide and grow and change it. It's just a neuron. It just sits there and does all this chemical stuff. Whereas the glial cells are the act of cleaning up, doing things. They form the cancers. So you've heard of astrocytomas or glioblastomas. Those are all glial cell cancers. Cancers of the glial cells we talk about. Second, these are primary brain tumors. These are metastatic. These are cancers of your lung, cancers of your breast, cancers of your colon that then send a tumor cell up to your brain. Okay? So two kinds of brain tumors. Primary brain tumors, glial cells mostly, and metastatic disease. Surgically, you can remove either one. But if you've got metastatic disease from your breast or your lung going up to your brain, you probably have more than one little metastases they found. You probably have 3 or 4 or 5, and you probably have spread in other places. So these, if you've got a metastatic tumor to your brain, are bad things. Probably not going to be having surgery to remove them. Probably have more than one in your brain. Not good. These you can take out and get rid of very frequently. Sometimes because of any kind of surgery of the brain requires you to cut out neurons that are doing good things because there isn't a clear divide amongst them. So you're going to get some, and you're going to be left with some functional loss because you've had to cut out that tumor. So, tumors of the brain, two primary things. Trauma. I've mentioned falling. I tried to show you the layers of the brain and where the blood vessels were, and what happens is you tear a blood vessel. So it's underneath your brain, in that connective tissue lining that I mentioned, like saran wrap, where the blood vessels pass through that, and you rip it. Then you get bleeding in the brain. Depending on where you ripped it, depending on the kind of fall that caused it, that bleeding could be a small amount or it could be a very big amount. And as we get older, and those tissues get a little bit more wibbly, not as strong, the tearing happens more frequently. So we see a fair number of older people with minimal trauma, tore an area, and now they have a collection of a small amount of blood underneath their dura layer, underneath that saran wrap, called a subdural hematoma. Sometimes we leave those because the bleeding doesn't continue. It's not causing any problems. Sometimes it causes enough problems we've got to get it out. That's falling and things. Now you can get hematomas and bleeding not due to head trauma. Okay, I'll talk about that too. But head trauma related bleeding tends to be from falling or hitting your head, tends to be subdural bleeding from tearing those little tissues there, and it tends to be a smaller amount of bleeding in general that can be removed. People can do just fine. So when you go in to see a doctor and they say you have a subdural collection of blood, someone's going to talk about should it be removed or not, how big is it, how much problems do you have. But that's subdural. The symptoms, if it's bad, tend to be nausea, confusion, personality changes, drowsiness, a headache that's bad after trauma of some kind to the brain. A fall, a hit in the head with something. Okay, now there's blood deep in the brain. That blood causes, when you have problems with it, causes strokes and bleeding. That's not subdurals, that's not traumas, that's hypertension-related bleeding. It bursts an artery in your brain. You get a stroke with a clot that goes up to the brain and it blocks the blood supply. This is blood supply deep into this tissues of the brain and creates bad things in your brain. You know, the bleeding can happen in a variety of places, and so there's an intracranial hemorrhage, not a subdural, and you have it from strokes or aneurysms inside the brain. You've heard over the last dozen years, we've tried to come up with ways of saying we have stroke centers. Because if you can identify a stroke early happening, we might be able to undo that block or get that clot out so that the brain tissue, the neurons past that area, survive. So the treatment of acute stroke has become a thing in America. And there are stroke centers, and they've been out doing their best to teach everybody how do you identify an early stroke and get to the emergency room quickly so we can treat it. So this is one of those. Be fast and get to the ER. If you feel like you have an acute loss of balance, your sudden loss of vision, your face looks like it's drooping, your arm is weak, your speech is difficult, you need to call 911 quickly and get in to see if we can fix that bleeding problem so that you don't end up having damage to your neurons that lives the rest of the life. So there's a big push to try to do stroke treatment quickly. Okay. Every medicine that we've ever made in America and anywhere in the world are risky and hurt the brain. Every medicine we've ever made hurts the brain. So, if you want to just go to the grocery store and pick up medicine off the shelf that you're going to start taking because some friend told you to do so, watch out. It can hurt the brain. So you've got to be really careful as you get older with taking over-the-counter medicines, particularly high likely you're on other prescription medicines. And the interaction between medicines is bad. So a normal young person brain who takes a Dramamine, who takes a Benadryl, will get a little bit tired, a little bit sleepy. An elderly person who takes one Benadryl or one Dramamine could end up crazy as a loon, delusional, acting out, confused, same drug, same into one person, same dose, two different people. A young brain that can tolerate it, an older brain that can't. So be really careful with medicines. Medicines usually cause memory loss, confusion, and agitation. That's the symptom. So if some friend of yours or yourself and your kids notice that you're being more memory trouble now all of a sudden in the last week, more confused, more agitated, more anxious, ask what drugs you've been taking. What are the new drugs you've used? There's illnesses of the brain that we call degenerative brain diseases. These are neurons die. I've told you how important neurons are. I told you how many you lose through your life. It's crucial you have all your neurons. And for some reason, now they start to die. And they don't just die all over the brain. They usually start in one area. And depending on what area that's in, the symptoms of what you have. The most common are two main diseases. Neurons dying in an area of the brain called the substantia nigra, which is the center middle of the brain. And those cells are essential for you to control your movements. And people who have brain neuron death in the substantia nigra have Parkinson's disease. Huge number of patients with Parkinson's disease. Why do those neurons die? We don't know. We know what chemicals they make, and that's what I told you before. We try to get dopamine back to help treat them. But the problem is, you've got, and I'm going to make up numbers, 40 billion substantia nigra neurons. And you don't get symptoms until 20 billion are already dead. So now you start to see your first symptoms. And I'm going to give you dopamine, which is going to replace the chemicals you're missing, but those other 20 billion neurons start to keep dying. Dopamine doesn't stop them from dying. So you have a degenerative disease of the neurons that are killing them off, and we can't stop that. We can treat the symptoms you're having by giving you some chemicals that's their lack is showing up and causing, but we can't stop the degeneration. The second most common is an illness called Alzheimer's disease, where the neurons are being killed and they're dying, and it's happening in the temporal parietal lobes on the sides where your memory sits over time. And it spreads, and it keeps going. And it goes from you start to lose memory for about 15 to 20 years where you can't remember how to swallow, you can't remember how to hold your head up, and you're going to die. And it's a degeneration of the neurons. You slowly are losing neurons in those areas. Why is Parkinson's happening, and why is Alzheimer's happening, and what's causing that degeneration? We don't know. Nobel Prizes all over if you can figure all that. So, dementias and Alzheimer's is probably even more common than Parkinson's. Parkinson's is second. I threw on Lewy body here just so I should mention it. So, you want to know, this is how complex it is. So, I'm going to do an autopsy, and I'm going to look at the neurons that have died in this person who's had memory trouble, and in this person who's had memory trouble. And they don't look a whole lot different. Maybe there's a few things characteristically when they were alive that they look different to me. But I look at the neurons, and they've died differently. The Alzheimer's neurons have been destroyed, and they have what are called plaques and tangles formed by a protein called amyloid. And these neurons have a little round protein body in them that looks like the neuron has an owl eye in the middle of it. And Dr. Lewy described that, and so it's called a Lewy body. So the two neurons in this patient, two different patients, look different in how they die. And they do have a few different symptoms. People with Lewy bodies have more common Parkinson's things because of that association of that kind of cell death happening in the substantia nigra. The Alzheimer's people have the dendrites and neurons that are being destroyed more frequently, and the structure of those tubules is more prevalent than it is with the neuron damage of Lewy body. So you can distinguish them a little bit, and clinically, Lewy body dementia has some Parkinson's features. It has a shuffling, it has a little tremor, it has Parkinson's-like features to them, but they also hallucinate more than Alzheimer's. Alzheimer's people don't hallucinate. So you've got some subtle clinical differences where you say, aha, this person who I'm talking to now probably has Lewy body dementia. Lewy body dementia, progressive damage to neurons. The damage creates an owl-eye look. Alzheimer's, progressive loss of neurons. The damage creates neurofibrillary plaques and tangles. Damage to neurons, the same. It's damage to neurons, and it just keeps going, and we can't stop it. You've heard of a few others. Huntington's, which is a genetically programmed damage to neuron generation, can't stop it. ALS, amyotrophic lateral sclerosis, isn't a brain disease. It's the degeneration of neurons in part of the spinal cord. So it isn't a brain, it's a peripheral, it's a spinal cord disease. And then your macula is actually neurons in the back of your eye. You have rods and cones, a macula, and that degeneration is a neurologic degeneration. So like Alzheimer's, those are the neurons are in the back of your eye. So what's interesting is we're on the brink of new treatments for Alzheimer's and macular degeneration. And it hasn't yet caught on in the middle ones, but you need to know that the current state of the art in medicine is we might have a link to do something to stop the degeneration of those neurons. In general, there is no treatment for those deaf neurons, and the treatment is always dealing with symptoms. We alter the neurotransmitters by giving you chemicals. However, macular degeneration of Alzheimer's, we now have drugs called monoclonal antibodies. You've heard of them recently in the COVID era, where we developed monoclonal antibody treatment against COVID, and many people were going into ERs to getting infusions of chemicals to try to stop that COVID from going in. They are a scientific discovery of manufacturing antibodies, and we now can manufacture antibodies that will attack the vascular system that causes the adjacent problems in macular degeneration. Not as perfect as what we think we're doing with Alzheimer's. We've got monoclonal antibodies against amyloid protein that's causing the neurons to die. So in early Alzheimer's, we can infuse in these chemicals and stop that from continuing to grow, that neuron damage continuing to spread. It's new, it's been out for probably 2 years, it's really early. It's really important for people with new look of Alzheimer's. If you wait 15 years and the neurons are already dead, this stuff isn't going to work. You got to get when the neurons are starting to be damaged so you can stop that damage. So new Alzheimer's patients, see your doctor, talk about you're worried about the Alzheimer's, talk about monoclonal antibody treatment. It is the right thing for you or your loved one. You do all that, and you might be able in Ventura County to find 20 or 30 people that we could stop from going on to develop further Alzheimer's. That would be wonderful. Now, maybe it's more hundreds. I don't know. I don't know how effective this is going to be. And over the next so many years, there may be new things, but monoclonal antibodies are the hot item, particularly in Alzheimer's disease. In brain structure and function, we did aging changes, speed, processing, memory. We did how to preserve your brain function and exercise being probably the most important, both body and brain. And we talked the most important diseases. I think I did it.